इसमें how do I sign this? Good morning. How do we write that? ये इसको क्रॉस करो. Okay.
Live chat.
Okay. Nobody has joined in, I think.
Okay, 11 has.
Okay. Start कर दो.
11.
हाँ, but this is good morning. Okay. Okay. Good morning to all. Today's PG lecture is the topic is universal screening for congenital human cytomegalovirus infection in India. And I'll cover this topic with the following layout. I'll introduce the audience to the virus and then briefly to the congenital CMV infection epidemiology in our country and globally. Then we'll discuss the data from AIIMS on community-based studies which we have done from our lab in the country, followed by the important issue of congenital CMV infection and sensory neural hearing loss and the delayed sequelae, including neurodevelopmental issues. Then we'll come to today's topic proper, which is the screening of CMV at the neonatal period. And we'll see if we are able to satisfy the Wilson and Jungner's criteria for population-based screening, and which of these are fulfilled by congenital CMV as an infection and disease. And then we'll discuss briefly the issues related to implementation of universal screening in our country. Then we'll end up the session with clinical cases and conclusions. So when we talk of this human cytomegalovirus, simply called CMV, it is a ubiquitous virus and it has a worldwide distribution. Everywhere in the globe, in humans, where it has been looked for, HCMV has been found in the population. It's a typical herpes virus, one of the largest family of viruses. This virion is 200 nanometers in size. It's an enveloped virus with a double-stranded DNA genome. The length of the genome is 240 kilobase pairs. And one important property which this virus shares with all its other members is the establishment of viral latency. Now, viral latency is a very important property which the herpes viruses have. And it has been most well studied in the herpes simplex virus type 1 and 2. But we know that all herpes viruses share the same property. In this, for the herpes simplex virus and for the varicella zoster virus, it was the neuronal cells which were the main reservoirs for latency. In this case, many cells in CMV, I mean in human cytomegalovirus, many human cells are the reservoirs for and have the capacity to, the virus has the capacity to establish latency in these cells. The most important of these cells is the monocyte-derived dendritic cell precursors and in the bone marrow, and it is this cell which is the main site of latency of the virus. Other than this, many other cells in the bone marrow, in the epithelial cells in the body, and once the virus enters into the human body and causes a primary infection, which usually in most cases is asymptomatic, it establishes latency in the bone marrow and other cells. And then it also establishes latency in the epithelial cells. For example, the two main sites for latency in the epithelial cells or organs of the body is the kidney and the salivary gland. In the kidney, in the DCT and in the salivary epithelial cells, the virus establishes latency and replicates in these cells for the life of the individual and is shed in the saliva and the urine, even in healthy situations. So it reactivates now and then because of stressors or otherwise and is shed in the urine and saliva of the host. Of course, we know that the clinical spectrum of CMV is very wide. The most important disease as of now is congenital CMV infection or congenital CMV. Then it also may be acquired perinatally and leads to a perinatal CMV infection, which is usually benign. Then if the person has not been exposed to the virus at the stage of infancy or in the fetal stage, then primary infection can present as HCMV mononucleosis, which is very similar to EBV-induced infectious mononucleosis. Besides this, the virus is an important cause of infections in the immunocompromised group, especially in the solid organ transplant patients and the hemopoietic stem cell transplant recipients and HIV patients with HIV, especially when the CD4 count goes down. And now we also know that it is responsible for infection and disease in ulcerative colitis and is responsible for severe steroid refractory CMV infection in this population. So CMV has a huge clinical spectrum. It's a ubiquitous virus. Now, before we go on to the congenital CMV, let's first see the incidence of CMV, the epidemiology of CMV as ascertained by IgG antibody. Now, if we look at the studies which have been done, and they have been done from many parts of the globe now, in general, two trends emerge. The developing countries, there's a different trend, slightly different trend, and in the developed countries, a slightly different trend. Now, if you measure in healthy population, if you take the sera of healthy people in the population and do IgG antibody test for CMV, the seroprevalence of CMV by this test comes out to be 95 to 100% in developing countries, which means most of the healthy individuals in young age are exposed to this virus and it becomes latent, establishes latency in them, and it's universal, almost universal. Most studies in India have shown a seroprevalence of 98 to 100% in most populations which have been studied. So it's as high as that. So almost everyone harbors this in the developing countries harbors this virus in their bodies, in the bone marrow and other cells, and sheds it periodically in the saliva and urine. Also, it's important that the immune system keeps a check of this virus in all situations, and only in the immunocompromised does it actually lead to severe disease, for example, transplant recipients and HIV. I'm talking about the non-congenital scenario here. As far as developed countries are concerned, the seroprevalence is not as high as 95 to 100%. It is the range of 60%, 50 to 70%. The maximum data comes from USA, Canada, and other countries from Europe, and it ranges around 60%. So, what are the implications of this seroprevalence in terms of congenital CMV? Let's see that now in the next slide. So now if you look at the incidence epidemiology of congenital CMV infection in the fetus and babies and neonates, here we measure it by live births. So in the developed countries, it's slightly lower. It's 0.6 to 0.7 of percent of live births. And in the developed countries, developing countries, it varies from 1 to 5%. And this is the general trend. All countries, developed and developing, fit into this percentage more or less. That's why these percentages have been given for these populations and countries. So this means that 0.6% to 0.7% of all babies born in developed countries will be infected by CMV at birth. Similarly, in developing countries, 1 to 5% will be infected at birth, and this will be called, they may be symptomatic or asymptomatic. In either way, infection means they are proven to have CMV infection by PCR from urine or saliva in the baby at birth. Now let's come to two studies which the virology lab did in the last 10, 12 years. These are community-based studies. There are lots of papers on IgM-based prevalence of CMV, congenital CMV. There are papers on CMV based on PCR, but there are very few studies which are community-based. Now here, the two studies which were done by with CCM department in Ballabgarh, the outreach facility of community in Ballabgarh, and with the ENT department. One study was done in 2008, wherein 423 consecutive babies were tested for CMV. Saliva or urine was collected, and PCR was done in newborn babies, and it was found that the prevalence was 2.1%. 9 of 423 babies had CMV infection at birth, as proven by PCR. Then one more study was done in 2017, a similar study in which a much bigger population of 1,720 babies were tested. Consecutive neonates were tested at birth, and 20 of them had CMV infection as proven by PCR. And it was this, in a bigger study, it comes to 1.2%. So we can determine, at least in our population, the prevalence of CMV infection in newborns ranges from 1 to 2%. Now, let's now also first study the dynamics of pregnancy, transplacental transmission, and infection of the fetus and hence the neonate in this scenario. Now, if a woman is exposed to CMV in pregnancy, it can either be a primary infection or it can be a non-primary infection. Primary infection is the first time that the woman has been exposed to the virus in pregnancy. In this situation, since this is the first exposure of the woman to the virus, the transmission across the placenta to the fetus is very high. It's range of 30%. So one third of all babies, ranging from 20 to 40%. Now, if it's a non-primary infection, which could either be a reactivation of the woman's own latent virus, or she's reinfected by a different strain or a genotype of CMV, which is rare, but it does happen. So, for all practical purposes, non-primary infections are usually almost always reactivations. This one, and in our country, based on the prevalence data which I discussed in the previous slides, you will appreciate that primary infections are very rare or unlikely in our population, because by the time a woman reaches reproductive age, most of us have antibody to the virus and been exposed to the virus, and it's sitting in our bodies in the latent state. So in our population, if congenital CMV happens, it's due to reactivation or very rarely reinfection. Almost always it's a reactivation of the woman's own latent virus. And in this scenario, since it's not a primary infection, the viremia is not that high. So the chance of transplacental passage of the virus to the fetus is low. It's quite low. So you can see if the primary infection leads to a 30% risk of the fetus having CMV transmitted transplacentally. Here it's 0.2 to 2%. So you can take an average of 1%. So from this slide we can infer if the maternal infection exposure to CMV in pregnancy is a primary infection, the risk of fetal transmission is high, and the risk is around 30%. If it's a reactivation, it's just 1% with this range as I described earlier. And the last thing in this slide important to note, that the risk of primary infection leading to a fetal transmission is 30 times higher compared to a non-primary infection. This and this. Okay. Now, what are the clinical features of cytomegalovirus inclusion disease if the baby is symptomatic? The important features are intrauterine growth restriction, or IUGR, prematurity. In the CNS, the virus is neurotropic to this, and it infects the brain and the inner ear, which are the important delayed sequelae of the virus. So the brain, the involvement of the CNS may lead to microcephaly, especially in severe cases. And in typical scenario, you will have periventricular calcifications, which are hallmarks which you can see on radiology. Psychomotor delay, seizures are manifestations of CNS disease in these babies. In the abdomen, hepatomegaly, with or without splenomegaly, this is the most important clinical manifestation of congenital CMV, hepatomegaly, with or without splenomegaly. Some of these babies have severe cholestatic jaundice, cholestasis, which may lead to jaundice. The other manifestations are the vasculitis, which occurs and leads to rash. The rash is basically petechial or purpural in nature, and in severe cases, the extramedullary hemopoiesis induced by the severe CMV infection leads to a blueberry muffin rash. So, petechia purpura or blueberry muffin rash, which are islands of extramedullary hemopoiesis in the skin, are the cutaneous manifestations of congenital CMV. In the ear, one of the most important manifestations is sensory neural hearing loss, and in the eye, chorioretinitis. In the labs, an important feature is thrombocytopenia, which is observed in a big chunk of these babies, anemia in some of these babies, and the liver involvement may lead to a raised ALT in these babies. So the important features are IUGR, prematurity, microcephaly, psychomotor delay, seizures in the abdomen, hepatosplenomegaly with or without jaundice, petechial rash, purpuric rash, or blueberry muffin rash. In the ear, sensory neural hearing, special senses, SNHL, that is sensory neural hearing loss, and chorioretinitis. Of these, the features marked in blue, especially psychomotor delay and sensory neural hearing loss, may not be early manifestations in some of these babies. The baby may be apparently normal at birth, and later, in the next 2 to 3 years, up to 5 years, they may develop the neurological manifestations like psychomotor delay, and especially sensory neural hearing loss can occur even up to 5 to 6 years. And it may not be manifest at birth or in the first few months of life. Now, this is a very important slide to understand the natural history of this disease. So as we discussed, in our population, around 1 to 2% of babies get infected by this virus at birth, as proven by PCR-based studies I discussed two studies which our lab did in the slides previously. And it's important to understand that most of these babies are asymptomatic at birth. So if you take 1,000 babies, around 13%, so 12 to 14% average to make it easy, 13% will have symptomatic CMV disease, which is the features of which I just discussed in the previous slide. And 870 or 87% will be asymptomatic. They will be apparently healthy and normal on physical examination at birth. Unless you do invasive tests or detailed investigations like a CT scan for the brain or a hearing test, which may be normal at that time, okay, they'll be apparently healthy and normal. But what is important to understand is that now first let's discuss the symptomatic babies. The 13% babies who are symptomatic, some will have severe, very severe disease and may not survive from the neonatal period, and this contributes to a 4% mortality. The remaining 96% children are equally divided into either they have no sequelae at all, they recover from that disease, they have mild to moderate disease, and they have no permanent neurological stigmata, and they recover. The thrombocytopenia improves, the hepatomegaly improves, and with medical management, the other issues also improve. But half of them, 48% of this 130 group, symptomatic group, have delayed sequelae. Now this is the most important. This was what was thought was the natural history of CMV till now. But now we know that these asymptomatic babies are not fully asymptomatic. They are apparently normal at birth. But as the age advances, 4 months, 6 months, 1 year, up to 5 years, some of them do develop delayed sequelae. And this contributes 14% of this. If you take this as 100%, 14%. Now it's important to understand that the contribution of delayed sequelae from the asymptomatic group is always 14% of this, but this is a bigger chunk. So it is 120 babies approximately, and this is double than this number, which comes from the symptomatic group, which were diagnosed at the neonatal period. So the delayed sequelae, the contribution of delayed sequelae is 1/3 from the symptomatic group, but 2/3 of that, you can see this 120 is double of 62 in numbers. Just to make it easy to understand the percentages and numbers, it's quite evident from this slide, from the natural history, that a big chunk is normal at birth and they have delayed sequelae. Now, which are those delayed sequelae? So around 120 babies come from here and 62 babies come from here. So 182 out of 1,000, 18.2% of the babies ultimately have delayed impairment. There are two delayed impairments. The most common is audiological, that is sensory neural hearing loss, and many of these babies have profound deafness. And the CNS damage, which leads to neurodevelopmental delays. Now, so if we discuss in brief the pathogenesis of CMV, congenital CMV infection, around 1% of fetuses get infected in our scenario, and this leads to a placentitis. Now here I want to emphasize one thing. Most congenital infections, now if you think about the list of congenital infections, we have viruses constitute the most important, CMV being the most important of all the pathogens in the group. CMV is the most common agent. After that, you have so many viruses like you have rubella, you have Zika, you have HIV, you have the varicella zoster and other herpes simplex and other viruses, and lymphocytic choriomeningitis virus and others to complete the list. But CMV tops that list here. Then you have, in the parasites, you have Toxoplasma gondii, a very important congenital infection. And in bacterial infections, you have two, the most important being syphilis, congenital syphilis, and then you have the rare case of congenital listeriosis. There's a term for that which you can find from the textbooks. So that is rare, but nevertheless, of all these infections, whether it's syphilis, Toxoplasma, Zika, CMV, HIV, some of these pathogens lead to a placentitis-induced congenital injury, whereas others simply traverse the placenta without a placentitis. For the PGs, please make a list of placentitis-induced congenital infections versus congenital injury without placentitis. This is a homework for you. Now, so the main areas affected are the liver, hepatomegaly, the rash. You can see here a petechial rash in this baby, CNS involvement with cysts and migration abnormalities of CNS, and of course deafness due to damage to the cochlea and the post-cochlear neural network. Now, the two studies I talked to you about. Now let's in brief look at those studies in detail because they give us an insight into the issue of congenital CMV in our population. In the first study I talked about in 2008, this study had studied just 423 consecutive pregnancies and 9 babies had CMV infection proven by PCR. And it's important to understand that 7 of these babies were asymptomatic at birth. One had hepatosplenomegaly at birth. And one baby, because this study was a follow-up study for a few months, 6 months around. So at 4 months, one baby had hearing loss, which was not evident at birth. So it's in this small population, you can note that the baby was apparently healthy at birth, but had hearing loss at 4 months. Okay, and uh, so the delayed manifestations start coming up at 4 to 6 months and go on up to 5 years. That's important to understand. Hence, the need for universal screening of these babies at birth. Otherwise, a big chunk will be deaf by the age of 5, and you will never know the cause. The other was a large population-based study in which 1,720 neonates, newborns were consecutively, their saliva and urine samples were collected, mainly saliva, and 20 of these babies were positive for CMV DNA, and this constitutes 1.2% of the population. And all these babies were screened by two tests, audiometrically tests, that is OAE, that is otoacoustic emission, and the auditory brainstem evoked response, ABER test. And because genetic causes are the most important, the studies on genetic mutations were also done in collaboration with Dr. Madhurika Kabra in the Department of Pediatrics at AIIMS Delhi. And what is important here is the two babies who had CMV and had deafness, they were profound deafness. Whereas the uninfected, non-CMV infected babies had deafness due to various causes. They were genetic in nature, but it was not profound in most cases. It was one case had profound deafness, 5 had moderate deafness, 3 had severe deafness. So what is important is the deafness with CMV is often profound and severe and bilateral. And both these children have bilateral disease. So when CMV infects a baby, it's usually bilateral and usually severe, but that's not always the case. But yes, it is as severe in this scenario. So how do you diagnose CMV in a neonate who is born and is suspected of having CMV, or you're doing an asymptomatic baby screening for CMV? The gold standard test is now, the earlier gold standard was virus isolation in cell culture using the human embryonic lung fibroblast diploid cell lines, which we were doing earlier. But now it has gradually been replaced by PCR because of greater sensitivity and faster turnaround time. PCR for DNA, the preferred sample is urine and saliva and not blood. I'll tell you the reason why. Now, when has the infection occurred in the baby? It has occurred in the first or second trimester of baby, right? So the infection, by the time the baby is born, it's been 9 months, a few months down the line. At this time, the viremic stage of the virus is no longer there. There's no viremia persisting in many of these babies. In preterm babies, yes, we do expect a viremia, may be seen. But by the time the baby is born, the shedding of the virus occurs only in the urine and saliva, and the viremia is over. So that's why urine and saliva are better samples than blood in this scenario. Isolation in cell culture was the gold standard, now replaced by PCR. IgM test can also be done. It requires just an ELISA or a chemiluminescent-based system to detect IgM antibody. But there are issues of false positivity and false negativity with this test when we compare it to the gold standards, and hence it's no longer recommended for community screening. So in most countries, it's PCR-based screening, which is now the investigation of choice and the standard of care for this population. In case if you have a tissue sample with you, which is only done in autopsies now, otherwise we rarely get tissue samples. You can see the typical owl-eye inclusion bodies of the virus in the tissue, and you can also demonstrate the antigens of the virus by immunohistochemistry, which is done by the pathologist. So these tests are rarely required in community programs. They are only based for research settings or in severe cases in the hospital. So, as we talk of in brief about the molecular assays, we have PCR-based CMV DNA test, which is you can do a qualitative PCR, you can do a quantitative PCR, you can do a conventional PCR, which is usually the nested format is usually preferred, or a real-time PCR. All are acceptable. The GB gene has been most studied, but other genes, conserved areas, regions from other genes have also been used, although GB gene remains the most commonly tested region for diagnosis. Samples, as I discussed, urine is the best sample. The reason simply being the shedding of the virus is very high in the urine. The viral titers in urine range from 10 to the power 6 copies per ml to 10 to the power 11, 10 to the power 12 copies per ml. In saliva, the values are a little lesser, but they are in the range of 10 to the power 3 or 10 to the power 4 copies per ml, which is good enough for any PCR to detect. So both samples are okay. The only issue with saliva is that if you have a saliva sample positive in a baby by screening, you have to do a confirmation by urine. So saliva can work as a first tier test, but a positive saliva needs to be confirmed by a urine test, simply uh, because of our high seropositivity, shedding of the virus in the maternal breast milk may be happening, and that may lead to a false positive result because you're testing the saliva of the baby, and the confounding of the mother's maternal DNA may happen. Hence, you need to confirm by urine PCR. We do get situations where saliva is PCR, urine is negative. So a urine positive is taken as the final test for confirming congenital CMV infection. Now, a very important issue here is timing. You cannot test a sample beyond 2 weeks. You can take any sample anytime, but if a sample is taken beyond 2 weeks, the issue of perinatal transmission from the mother may be the cause of the positive PCR, because in the first 2 weeks, if the child has acquired the virus in the fetal life, intrauterine, transplacentally, then in the first 2 weeks, there's no way that the virus it may be positive by any other way. But if the child acquires the virus during parturition and beyond, from the mother or from the siblings, then the shedding of the virus out in the third week and beyond can be due to perinatal transmission, which is usually benign. So, to be sure, uh, first 2 week sample is the best sample. Up to 3 weeks is acceptable. After 3 weeks, the samples, then you can collect a sample and retrospectively correlate clinically, but you can never be sure whether this was a congenital transmission truly or a perinatal transmission. So isolation in cell culture using fibroblasts was the gold standard, but no longer done because of sensitivity and of course the turnaround time. IgM has its issues in false negatives and false positives. It's important to understand that even healthy neonates may not be able to mount an IgM. It's textbook information in any virology book that 10 to 15% of neonates may not be able to mount an IgM to any pathogen, not just CMV. This is general for any pathogen. Also, it's important to note a higher percentage of preterm babies may not be able to mount an IgM. So, it may be leading. So, testing alone by IgM may lead to false negatives because of these reasons. And of course, false positives may happen with any new capture or any IgM format of ELISA or any ELISA for that matter, because of cross reactivity with IgM due to other related viruses or non-specific polyclonal stimulation of the immune system, say, and or by serotype factor, etc. So these are the issues why PCR remains the test of choice in diagnosis and in community surveillance, if at all it needs to be done. This study from the NEJM had compared a huge bulk of 34,989 infants with with saliva testing compared to urine. In the 177 babies which were positive for CMV, the liquid saliva samples had a concordance almost matching with urine, the gold standard. And hence, in a community setting, saliva is much more easier to obtain than urine. In case it's positive, then you may take a urine sample from only those babies where you need to rule out true infection. This is a small study. This is actually my MD thesis in here in the virology lab in AIIMS, where we have compared saliva, urine, and blood. Blood was, as you can see here, the blood PCR had a sensitivity of only 38% because by the time the baby is born, the viremia in the blood is not there much. So the sensitivity of blood PCR is much lower than a urine PCR or a saliva PCR. And that's the important thing here. The same thing applies for antigen detection. We had also compared antigen detection with blood PCR and seen that antigen detection is not as optimum as blood PCR also. So the standard tests remain urine and saliva sample PCRs. It's good to know that we have an antiviral which is available for this drug and for this virus, and we have ganciclovir, which is given intravenously, or valganciclovir, which is an oral drug, which needs to be given for 6 weeks. At the moment, the indications to use this drug is for severe symptomatic babies only, those especially who have CNS involvement or sensory neural hearing loss or disseminated life-threatening disease. Otherwise, there's no indication to use ganciclovir otherwise in this scenario. And most centers have now started using ganciclovir or valganciclovir in as per these recommendations. There are no established guidelines, but yes, many important bodies have given their recommendations which state that this drug can be used. The only issue is the neutropenia induced by these group of drugs. These are DNA polymerase inhibitors and used early in such babies, they have a higher rate of preserved normal hearing and improved hearing in these babies, with prevention of worsening of hearing in those who had a baseline deficit. Also, development delays improve with time in these babies, if not in every baby. So the only thing is the pros and cons of weighing of giving this baby a normal life, if at all, compared to the side effect of neutropenia, which is seen around 10 to 15% only, or severe neutropenia. So the monitoring the absolute neutrophil count is essential if giving these antivirals for congenital CMV. And once the baby is diagnosed, what are the things you need to follow up for these babies? You have to monitor these babies with many tests. One is so growth, physical, and neurological examination, developmental assessment. These are tests which have to be done for these babies. These babies may need to have an audiometric test for deafness if they are healthy at birth, especially, and if they have issues, then they need to be followed up in the ENT department. Fundoscopy if the baseline was abnormal for chorioretinitis. The blood tests, there is no issue. Liver function tests, especially the ALT and the other liver function parameters. In the hemogram, platelet count is the most important, followed by the hemoglobin and other parameters depending on the case to case. Now, all these tests have to be done at 1 month, 3 months, 6 months, and then at 1 year, and then annually till the child enters into school. So around the age of 5 or 6, depending on the country and the screening program they have. Now, the most important delayed sequel of CMV is sensory neural hearing loss. Now, it's been shown that it could be mild to severe, it could be unilateral or bilateral. And sensory neural hearing loss by CMV is now regarded as the commonest cause of non-syndromic sensory neural hearing loss. Now, all babies who are born with hearing loss at birth, almost all 70 to 80% causes are genetic, syndromic. Okay, so it's not infections at all. The only infectious agent recognized and identified, which is of clinical importance for delayed sequelae, is CMV. So many studies have shown where they have studied the viral load in tissue in babies with the hearing loss, especially in the babies who could not survive, and they have found the highest viral load to be in the inner ear, in the organ of corti, also in the vestibular labyrinth, in the crista ampullaris, and other parts of the inner ear, which has proven the association of the deafness induced by CMV and its presence in these tissues. Now, the two tests which are important if you have a screening program for CMV, we need to go back to a few years back to our MBBS times. We remember the auditory pathway from the inner ear to the organ of corti to the spiral ganglion we have the cochlear nucleus here in the brainstem, the midbrain, and then the primary auditory cortex near the medial geniculate body. So it's here that the entire pathway may be affected by CMV at any stage. The maximum damage occurs here in the cochlea, but post-cochlear neural damage is also known. Hence, two tests have to be done for CMV. One is a simple otoacoustic emission OAE, which measures the function at the level of the cochlea and before that. And then to see post-cochlear neural damage up to the auditory pathway, an AVR test is the only way to know that. Both are non-invasive tests. They can be done by simple machines. In the auditory brainstem, it has to be done in the audiometry lab, whereas OAE can be done even in the field. So a good screening test is OAE, otoacoustic emission test, whereas auditory brainstem evoked response, ABER, or BERA it was called earlier, needs to be having in an audiology lab. Any ENT OPD can have it. All medical colleges and district level hospitals, many of them have these facilities now, and hence these tests can be performed at the screening program level now. Now, this article from NEJM shows the importance of CMV as a cause of deafness in the neonate, and then these children were followed up till the age of 4 years, and you can see CMV constitutes to around 21% of deafness. Of all causes of deafness only we are seeing. Whereas as these children are followed up, it becomes 25%, which means a 4% increase, which means many of these babies were normal. They were normal at birth. They had no screening sensory neural hearing loss at that age at birth, but some of them developed sensory neural hearing loss in the ensuing years and which this chart is enough to show that early screening is important because many of these babies are healthy at birth and they lose their hearing by the age of 4 or 5 or 6. A lot of studies have been done on hearing loss, and they have shown a 14 to 18% CMV as a cause of deafness in growing children. When they went back and tested their samples, the blood samples especially, that's the only sample which was preserved, the DBS. You know that in many countries, in developing countries, especially US, they have Guthrie cards in which they preserve the dried blood spot samples, and these were retrospectively tested in some of these studies. So urine saliva are not available at that time when the child is 5 or 6. But as I said, there are issues of the blood, so we need to uh, shift to urine or saliva if at all we need to be sure of, if you want to go retrospectively, I mean. Many studies have shown that early treatment of these babies benefits, and hence the role of early CMV testing for these babies. Uh, of course, it's important to understand it's not just about drugs or antiviral drugs which we can give in the early part of life to save the ear and the brain. It's also important to understand that non-pharmacological management is also equally important, or has a pivotal role, because hearing aids, cochlear implants, and speech therapy, these together preserve hearing. Whatever has been lost is lost, but you can. And one important thing to understand here is the concept of deaf mutism. This term was used earlier, 2 decades back. If a child cannot hear, he will not develop speech, right? So if you're able to preserve the hearing by hearing aids, antiviral therapy, if at all it's indicated and if it's given, fine. More importantly, and equally importantly, I would say, is to start management of hearing by giving a hearing aid or a cochlear implant if it's feasible, or and together with speech therapy. This improves hearing and makes these children productive in life. Otherwise, they are all they're not contributing to society, and they live their lives in this way as deaf, mute babies and children. So it's important to understand that this screening can help many such babies. Now, we'll discuss the problem statement in the next few slides. Now, when we talk of screening, if at all we need to screen a baby and prevent such deafness in many in these children and babies, how do we see whether we are able to satisfy the policymakers that we need to have a screening program? And the gold standard criteria for screening any disease, it's not infectious disease, any disease for that matter, is the Wilson and Jungner's criteria. Now, what are these criteria? Okay, so before we go on to the criteria, what kind of screening can we do in the first place? The screening of these babies can be targeted, as much as what we are doing now. In India, we are not doing any screening, except those 2 studies I showed you. There is no population-based study in India at the moment. But this is targeted screening. If what we can do, which is easier, is targeted. That you perform hearing tests as part of a program or a policy, and if the neonate fails these tests, look for CMV as a possible cause. But of course, if the hearing is is at birth, it will be detected. Okay, and but if the hearing occurs later, the neonatal period has gone, then you cannot go back and confirm CMV as a cause. That's the reason why universal screening is now what is the need of the day. Most countries now gradually shifting from, like US is doing targeted screening. Only some states have it as a part of law. Utah and Minnesota and 1 or 2 more states are doing it at the moment. But not all states are doing it there also. But many, with the data of deafness in growing children, it's now becoming clear that the universal targeted screening will not help completely, because not all babies will be having deafness at birth. Many will develop it by 4 months, 6 months, 1 year, 2 years to 4 years. So the only way to diagnose is to look for CMV in babies, and those who are positive, to follow them up if at all they develop disease, neurological or sensory neural hearing loss and other delayed sequelae. So, what are the classic Wilson and Jungner's criteria to screen a disease, to look for a disease or infection or an organism or a pathology in a population? The 10 criteria are the following. The condition should be an important public health problem. Otherwise, why will you have a screening program at the population level? There should be an acceptable treatment for patients with recognizable disease. Facilities for diagnosis and treatment should be available in the country or in the region. There should be a recognizable asymptomatic, pre-symptomatic, or latent stage of that disease. There should be a suitable test for examination to confirm and reliably diagnose that disease. The test and that test should be acceptable to the population. It should be a non-invasive test. It should not cause pain, invasive procedure, preferably. The natural history of the condition, including development from latent to declared disease, should be well understood. There should be an agreed policy on whom to treat as patients. The cost of case finding should be economically balanced in relation to possible expenditure on the medical healthcare budget of the country or region. And of course, the last point, needless to say, this case finding, if at all it started as a program, should be a continuing process and not a once and for all project. So once you start it, it has to go on because babies will be born, and you don't want to deny the future babies of a less significant future. So, is congenital CMV the next newborn screening frontier? Does it fulfill the population-based screening criteria I discussed? So let's look at the criteria in perspective of CMV one by one. So, the first criteria, sorry, yeah, the condition should be an important health problem. There's no dearth of data now that it contributes to around 18% of deafness in growing children, which are not looked for in the earlier, when they were born, they were not deaf, and later they were classified as deaf. So if 20% of these of deafness is contributed by one organism which can be prevented or at least screened and improved upon, it makes it a clear-cut indication for testing for such cause of deafness in these babies. Many studies have shown that universal screening is the only way out. If target screening, if not, you can't do universal screening, start with targeted screening and shift to universal screening once the policy becomes more clear and the issues of screening at the national level are solved. If I look at just our country, data from our country, it's the commonest cause of deafness, we know that. And 1% is, I'm taking the lowest percentage, 1% in India. If you take from the government websites, we have 75,000 babies born per day in our country. So 75,000 babies per day. This makes 1% or 750 babies per day having congenital CMV, and that makes it to 273,750 babies per year with congenital infection. And if you take 18% of these, that percentage, which has come from many studies now, we have 50,000 babies born per year who will become deaf by the age of 5, if not looked for, and we're doing nothing about them. So it's a public health problem. Definitely, it is one important problem. There should be an accepted treatment for these patients, and there should be a policy to whom to treat. That is also quite getting defined over the years. We know that we have a safe drug, we have an effective drug, sorry, for CMV. Although the neutropenia issue is important, we cannot negate that. But it's approved by FDA for symptomatic babies with severe disease. Many randomized controlled trials have clearly shown the benefit that if they are started early in the neonatal period, it improves head size, it improves milestones, reduces the risk of progression of hearing loss and its progression, improves speech and language outcomes in combination with hearing aids, speech therapy, etc. So, and then we also know that if it's given for 12 months, many reviews which have come from different studies have confirmed from developing countries also have shown. This study has said that the effectiveness, that seeing the scenario that we are missing cases at birth by not doing a universal screening, it's that they recommend oral valganciclovir for 12 months, and it improves outcomes in many of these babies. So it can be used at this as a therapy in these babies. Some studies have shown efficacy with 6 months of valganciclovir also. So 6 months to 1 year, that's a debate which needs a bigger discussion and bigger studies. But nevertheless, studies have shown now, coming from Brazil, US, Japan, have shown that yes, giving treatment immediately in the neonatal period preserves neurodevelopmental and sensorineural hearing loss in many of these babies. So these babies will no longer be productive parts of society, and it will be helpful for the population as a whole. Diagnosis and treatment facilities, these tests, which includes the availability of professionals like pediatricians, microbiologists or virologists, nursing, technical staff, good grade molecular laboratory which can do which has experience with PCR. Tests for audiometry like OAE and ABR are available even in medical colleges now. So such babies can be referred to medical colleges if you can't do these tests in the periphery. Okay. fundoscopy, if at all required, in visual issues, and these blood tests can be done anywhere. So that's not a problem. So our country now is good enough to have these facilities at the community level also. Okay. There should be a recognizable asymptomatic stage, and the natural history of disease should be known. This is very clear from the previous slides I discussed, that we know that a huge chunk is asymptomatic, but the delayed sequelae come from a big chunk of this bigger chunk, which contributes to double the number from the known symptomatic group and constitutes 18.2% of these babies having delayed sequelae. So the natural history is clear. The evidence is available from studies from our country, from abroad, from many parts of the world, that yes, it's a problem and it can be tackled, if at all, at the universal screening level. There should be a suitable test and it should be acceptable. These tests are, all it requires is a urine sample or a saliva sample, non-invasive samples, and if it collected within 2 to 3 weeks of birth, it establishes infection as a cause of the, it diagnoses the baby's condition. Audiology tests are available in medical colleges, and we have more than 170 medical colleges in our country. This can be done at the program level. That's why, because we have these facilities in most audiology labs of medical colleges also. CT scan, MRI are again easily available now in our country. Or from villages, the babies can be referred to the nearest hospital which has a CT MRI. So availability of testing and the expertise is not a problem in our country now for these tests. And finally, the cost of, now this is important, the cost of case finding should be economically balanced in relation to the possible expenditure on medical care as a whole. It's important to understand that now somebody may argue that we have so many other issues. Yes, we have many issues. But this issue is not less important, is what I was trying to say. We look at this JAMA Pediatrics review in 2016, which states that in fact, when they compare targeted screening, no screening, versus treatment of patients at deafness and cochlear implant later, which costs lakhs of rupees and millions of lots of dollars, compared to targeted screening, compared to universal screening by a simple PCR in urine, they found that universal screening offers larger net savings and greater opportunity to provide directed care. So it says that even if you do universal screening also, in the end, if you're able to diagnose and monitor these children and prevent a cochlear implant or give treatment and prevent severe disease and prevent sequelae, it works out cheaper actually. So now gradually in many states in the US, they are shifting from targeted screening to universal screening. So now, but also discuss the limitations of universal screening in our population. Since a majority of babies are asymptomatic and many of them will never develop sequelae, right? So 14% of the big asymptomatic group had sequelae. I'll just take you back to that chart. So if asymptomatic babies, 120 or 14% had sequelae, but 86% did not. Now all these babies will be screened and tested for. But as the reviews have shown, the meta-analysis have shown, it works out cheaper if you even screen each baby. Nevertheless, it's important to understand that since a majority of these babies are asymptomatic and develop sequelae later, and many will not develop sequelae, a bigger chunk will be recovering with no sequelae, sorry. A positive result will cause parental anxiety to those families and babies whose babies were screened. So that element of anxiety, which will be because our baby is infected by a virus, now that can actually be tackled by a good, good counseling. You can tell them that this is an infection which in many cases is asymptomatic and nothing to worry. In my thesis, I encountered many such parents who said our baby has been infected, but we had to give them counseling that in 90% cases nothing will happen. So they need to follow up those babies if at all they notice hearing loss or visual problems or developmental delays. The financial considerations in our country, that's important for the policymakers to decide if at all they need to have a program. And of course, the cost-benefit analysis of using antiviral therapy in severe cases, or in some of these cases, maybe some of them who are asymptomatic may need therapy, and the cost of neutropenia versus benefit has to be measured. So these are the three important issues which I feel we must consider before embarking on a national program at our level, in our country, in our population, with huge numbers, and many such babies with delayed sequelae with congenital CMV. So I conclude this lecture with the points that congenital CMV is the commonest agent to cause non-syndromic hearing loss, the most important infectious agent to cause deafness and neurological damage. Asymptomatic babies also carry a risk of 13 to 14%, I said, which ranges from 13 to 15% of delayed neurological or sequelae. Congenital CMV does satisfy the Wilson-Jungner's classic criteria for screening newborns at the population level. And it's time to initiate this as a national program to prevent 50,000 babies per year becoming deaf or neurologically impaired, who otherwise could possibly lead a healthy life, a normal life. Now, thank you so much. I finished this with three cases for our postgraduates. I want all the PGs to note down these three cases and email me your comments in one sentence or two sentences in the next 1 hour. The first case is a 1-week-old preterm baby who is undergoing workup for cholestatic jaundice, petechial rash, and thrombocytopenia. Congenital CMV is suspected. The IgM test is done first, it comes out non-reactive, and the simultaneous urine sample comes positive for CMV by PCR. So what are the possible reasons for this discrepancy among the two tests? And give your comments regarding your interpretation in this scenario. I'll email you these slides. You can take photographs of these slides at the moment, and you can then answer these questions down the line. So in this case, it's a 1-week baby with IgM non-reactive but PCR positive. So how do you interpret the scenario and your comments? Case 2 is where saliva and urine both were taken as a part of our national program. The saliva was positive for CMV DNA, but the urine sample was negative in this 2-week-old baby with hepatomegaly. So what is the cause, possible reasons for discrepancy of these two tests, and give your comments regarding the interpretation. And finally, I end with the case number 3. That is a 4-week-old baby is undergoing workup for microcephaly and hepatomegaly. Congenital CMV is in the differential diagnosis, and the urine CMV PCR is positive. Please comment. So this is a 4-week-old baby with suspected CMV whose urine PCR comes positive. What do you comment on this result in this scenario? I'll again focus these 3 slides for the postgraduates. You all have my emails. In case those of you don't have my emails, the newly joined residents, you can take it from one of your seniors. Case 1, 1-week baby with negative IgM serology, but PCR positive in urine. Comments and your reasons for discrepancy. Case 2, 2-week baby with hepatomegaly, saliva positive, but urine negative. Reasons and comments. Case 3, 4-week baby with microcephaly hepatomegaly, urine PCR positive. Give your comments for this scenario. Thank you so much. Any comments?
No, sir.
Okay.
No queries.
You can wait for 5 minutes in case any comments. Okay. Thank you.